Thank you guys so much for joining us for this awesome conversation about PCOS. It is PCOS Awareness Month. We've got some really great panelists today to chat with us. If you're joining the live stream, please know that you can add your questions for our panelists right here in the comments, and we can pop them up on the screen and address them. So I will start by introducing myself. My name is Savannah Levins. I'm a reporter for 11 Alive News, so some of you watching may recognize me, but I also have PCOS. I was diagnosed last year, and I'm 31 years old, so it's a little later than some other people I know who have been diagnosed with PCOS. My diagnosis came after I came off the birth control pill, which I'd been on for a very long time. To mitigate menstrual cramps. And so I was getting married. My doctor said, if you're thinking about having a family in the next couple of years, you might want to come off the pill, see what your cycle does naturally. So I did. And spoiler alert, my cycle did not ever regulate. So after a lot of back and forth with a lot of different doctors, and finally some testing and an ultrasound, I was determined that I have PCOS. So this is a relatively new thing that I've been facing within the last year, but I've definitely been spending that time trying to learn more about PCOS. One thing I've learned is it has impacted so many women and does impact so many people. So I have brought these wonderful panelists together today. So I'm going to ask that they introduce themselves one by one so you'll know a little bit more about their background. So Lindsay, would you like to start first?
Yeah, sure. Thank you for having me. My name is Dr. Lindsay Johnson, nurse practitioner, CEO, and founder of PCOS Sisters Telehealth Clinic. We're based out of Florida. We also are here in Atlanta, actually, where I live, and expanded to Texas and New York most recently.
Awesome. And can you tell a little bit about what PCOS Sisters is and what you guys do?
Yeah, so we're actually a multi-state telehealth practice. So we diagnose, we treat PCOS all from the comfort of patients' homes. We do require video to be on, but it's essentially concierge level medicine. You have a text line directly to your nurse practitioner who becomes essentially your best friend through the whole journey. We also have a health coaching and a workout program and diet program side of the practice, as well as the medical side. So you do receive your medications, your imaging if you need it, your labs all locally. Labs are sent immediately in the visit directly to Quest Diagnostics. And we've actually negotiated really great prices with Quest. So even if you're uninsured, we can get a $2,000 lab workup for about $200. So it's really great for, as y'all know, hormone lab workups are very expensive. So if the uninsured population oftentimes has difficulty getting diagnosed.
Yeah, definitely. I can relate to that. Martha, would you like to introduce yourself?
Yeah, again, thanks for having me. My name is Martha McKittrick, and I'm a registered dietitian and a certified diabetes educator. And I'm based out of New York City, but I have a virtual practice. And I've been specializing in PCOS since like the year 2000, as Sasha knows, a long time. And I don't have PCOS, but I get very interested in it, back in the year 2000 when I had my first patient with PCOS, and it was just very puzzling. I knew there was some insulin resistance involved, but we didn't know much about PCOS at all 24 years ago. So much less than we know now, but I just became very intrigued by it. And I got involved with some associations, started lecturing across the country on it, authored some chapters in a book. And I'm really passionate about it because I see the huge impact that nutrition and lifestyle can have on helping decrease the symptoms of PCOS and the health risks. And just so many people aren't getting the right information. So I'm super passionate about helping people who have it and about providing evidence-based information. So I'm very active on social media, and I'm really out there to bust myths because there's so many myths out there, which we'll get into, I'm sure. So I'm all about evidence-based and practical information to help people really take charge of their PCOS.
Yeah, you read my mind. There are a lot of myths that we're going to get into. Sasha, would you mind introducing yourself?
Sure. Thank you so much for having me. My name is Sasha Ati. I am founder and executive director of PCOS Challenge, the National Polycystic Ovary Syndrome Association, which I founded after my own diagnosis with PCOS and being dismissed by my healthcare providers. My doctor actually told me, Don't worry about not having your periods. Plenty of women would love not having their periods. The very reason for me presenting to her in the first place. And then
I was told the same thing. I can
it's
relate.
such a common myth because, right, periods are important. And that was her opportunity to educate me about PCOS and the connection to other comorbid conditions like endometrial cancer that can stem from not having your periods regularly. She also referred me to an endocrinologist who told me to come back to see him in 6 months after I'd lost weight without any tools, any real advice, right? So I had to take charge and do a deep dive into the evidence that was there, and found out that there were millions of others who were dealing with the same thing, who were confused, who felt alone and unsupported. And that's how I founded PCOS Challenge. And we also started on a mission to provide evidence-based information to the patient population, but also the general public and healthcare provider community. As we'll probably get into a little bit later, there's a huge problem with missed diagnosis. Of more than 50%, 50 to 70% of PCOS patients are going undiagnosed. So we started on a mission to raise awareness about PCOS, but then eventually figured out that we had to really lay some groundwork into advocating to raise the profile of PCOS, but then also advocating for increased research, increased funding, and better treatment options for those with PCOS.
Yeah, definitely. I can relate a lot to that as well. So for everyone watching the live stream, remember you can add comments and we can pull them up. I'm going to start with a few questions. The first one being just what is PCOS? And maybe Sasha, if you want to start us off, what is it?
No, PCOS, polycystic ovary syndrome or polycystic ovarian syndrome, is the most common hormone disorder in women. It's also one of the most common human disorders, yet most of us have never heard of it. It's a genetic condition. It runs in families. It can cause irregular cycles. It can cause signs of high androgens, or these are the male hormones, such as excess or increased body hair and facial hair, severe acne, and some on ultrasound may see some polycystic ovaries. So these are enlarged ovaries with immature follicles that can cause problems with getting pregnant. But PCOS is not just a reproductive disorder. It's connected to your metabolic health. 50% of PCOS patients are at higher risk of becoming diabetic or pre-diabetic before age 40. So in your teens, in your 20s, PCOS is a single risk factor for these serious comorbid conditions such as diabetes, cardiovascular disease, and as we mentioned earlier, endometrial cancer. And another really not well talked about underlying issue in PCOS is mental health disorders. And so we can delve a bit deeper into that, but from our PCOS Challenge's own research, over 60% of PCOS patients present with some form of anxiety, depression, or other mental health condition.
Unfortunately, that makes sense to me because of how isolating it can feel, which is why I'm so glad, we're having this conversation. And maybe, Lindsay, you can take this next question. What are the criteria for a diagnosis? If someone suspects maybe they have PCOS, what does that look like?
Yes, so I'm really glad you brought this up because you might be aware the latest updated guidelines, international guidelines, were in 2023. And that was the first major international guideline update since the early 2000s. So a lot has changed. So there's actually the two categories. You have to have either some sign of hyperandrogenism. Okay, that could be clinical symptoms like excess hair, acne, something that shows you have too much testosterone, or biochemical proof. So that would be a lab test for testosterone. But because the reason why you don't necessarily have to have proof on lab is because it varies from day to day. So what we found was a lot of women that had excessive hair growth on their face, when they just happened to come in that day for the lab test, the testosterone was not high. And then the providers way back would say, well, you know what, you don't have it. And this person would continue to progress. The second category is irregular cycles. Okay, that doesn't mean skipping a whole cycle. It just basically means like off by 1 week plus or minus. So people get confused by that too. If you don't have that symptom of irregular cycles, you can do a transvaginal ultrasound to look for the polycystic ovaries, or the newest addition to the guidelines is an AMH test. So that's the anti-Müllerian test. It's a blood test. Okay, so technically you can get out of you don't have to do the transvaginal ultrasound anymore, because you have to do blood work anyway to diagnose it. It is a diagnosis of exclusion, meaning you have to exclude every other endocrine disorder before you can call it PCOS. So that is the biggest part of the workup I see missing, is that they did not check a prolactin level, which rules out pituitary brain tumor. They didn't do an adrenal, any kind of DHEA adrenal tumor testing. And I get about 1 or 2 patients a year, not a lot, right? Because this is the rarer conditions that thought for over a decade they had PCOS and they had a pituitary brain tumor. So this is pretty serious. Like, that is why it is so important to follow the guidelines. Yes, a provider can tell you, they can just do a transvaginal ultrasound and say, well, yeah, you probably have it. Most women have it. It's 10 to 20%. Here, we're going to go ahead and start treating it. But what you don't realize is all those meds they give you to start treatment will mask the labs until the tumor is big enough. And then suddenly, years later, it might start growing more rapidly. It will basically mask the results we need to diagnose you. So you need to have the proper workup done before you start all the treatment. And that's the biggest mistake I see, is the initial diagnostic workup not being complete and someone being told you probably have it.
Can I
Yeah,
add to that? So the recommendation or the diagnostic criteria is you have hyperandrogenism or hyperandrogenemia. Hyperandrogenemia is you check the blood, you see the levels. If someone presents with a beard, that's hyperandrogenism, right? You don't need to do blood work to show that someone has high androgens, right? So the doctors who are dismissing these patients who are showing up with or who are bothered by excessive facial hair and saying, oh, you can't have PCOS because your blood work doesn't show it, because you didn't test your blood at a certain point in the day or a certain time in your cycle, is, that's just a part of why this condition is being going undiagnosed. It's just the lack of understanding by a lot of healthcare providers as well.
Yes, and I agree with that. That is a big issue. The education in primary care, I honestly think, needs to be improved quite a bit, because that's the first person that the patient contacts. So on average, the studies show it takes about 3 providers before you ever get a diagnosis, different providers. And some people give up before that, right? So that first contact, which usually occurs in primary care, that is the point at which they decide what happens. Do you go to endocrinology? Do I send you to a GYN? Do I handle it myself? So that's where the biggest change in education can happen as well, is on the provider side, and of course the patient side being self-informed.
Yeah. I can relate to that too. I think it took me six doctors, excuse me, to get my diagnosis. And I think there may be a misconception too. We all get our annual physical, hopefully, and you get blood work done, but the blood work we're talking about is not generally ordered in a workup like that, right? Is it going to take the patient to, request this type of testing, or a doctor just having a hunch, if those symptoms aren't presenting physically?
I think it's also tricky because many doctors are kind of used to somebody with PCOS being overweight or having a certain look. And if somebody comes in and maybe they're lean or they don't have hair loss, they don't have acne, the doctors might dismiss them, and it might not even be on their radar that it could be PCOS.
Yeah.
So I think it's important for the patient to really self-advocate and go in with the guidelines and say, can you refer, I think I have this, I want these tests done, or can you refer me to somebody who could do the testing? Because it presents very differently. And that's part of the confusing thing. The confusing thing is that, there are different phenotypes. And some people are very lean and they have more of the androgen issues, and some people have more of the fertility issues, and the classic PCOS do tend to have more weight problems and more of the metabolic issues. So I think unless the healthcare provider is pretty, well informed, it might slip through the cracks.
Yeah, I think two good tests. Do you have irregular cycles? And what irregular cycles are, do you menstruate less than 21 days apart or greater than 35 days apart if you're an adult, or greater than 45 days apart if you're an adolescent? That one question can help a lot to lead to a PCOS diagnosis. And then asking the history. Have you ever experienced facial hair or body hair that bothers you? Do you have excessive acne into adulthood or beyond your adolescent years? Do you experience hair loss? Because that's another sign of high androgen. So sometimes, yes, being a well-informed patient is a good thing. But I do think that we do have to take good histories as healthcare providers, ask the right questions to get to the right answer, right?
Yeah. And I also want to ask, since we're talking about being diagnosed, why is it important to have a diagnosis in the first place? Why is it important to be diagnosed?
I mean, I'll jump in on this. I'm a diabetes educator, and as Sasha had mentioned earlier, you want to be aware that there are some increased health risks down the line, and you want to make sure that you do, if you are getting irregular cycles, that you are getting screened for endometrial cancer, you are keeping tabs on your cholesterol levels, your blood pressure, your fasting blood glucose, a hemoglobin A1C, because there are much higher rates of diabetes and heart disease when you have PCOS. So really being aware of the potential health risks. It doesn't mean you're going to get these conditions at all, but there's, especially with diabetes and pre-diabetes, there's a greatly increased risk. So I think just knowing that I have PCOS, I have an increased risk of some of these conditions and the mental health conditions. I think oftentimes people just kind of suffer in silence and they don't say anything, and they think it's, it's my fault, or, but it definitely could be connected to PCOS. So being aware of these things, you can get screened for it and get treatment.
Yes, and basically it is progressive. So like later in life, you could start off being the thin phenotype where it's mostly, aesthetic. Like you might say, I don't want to have kids, or, it's just acne. It could start off that way, but eventually left untreated, what I've seen most commonly is by the time someone's 30, they do start to get the weight gain. The testosterone will eventually drive up insulin resistance and fat deposition if you give it long enough time, completely unchecked. With, of course, environmental changes go into that, but a lot of times it changes. You aren't stuck in one phenotype for the rest of your life. It can change over time.
And go ahead, Sasha.
Yes, sometimes even if you don't experience the weight gain, there may be central adiposity, which means that you have a tendency to hold weight in your stomach or in your abdominal area, not your stomach, but and just also based on your ethnicity or racial background, that can also influence how PCOS affects your life or what you're at higher risk for. So it's really important to get a diagnosis earlier on. And as Savannah, you and I can say, once you do get the diagnosis, there's this, oh, that's what was wrong. I'm not crazy, as some people may have told you, that it's all in your head, because medical gaslighting is real and gaslighting by other people is real. Oh, no. Yes, I am gaining weight without changing anything else about my lifestyle. I am rapidly gaining weight because of this condition. So the earlier you understand how PCOS affects you and impacts your body, the easier it is for you to kind of get ahead of it and help to instill some of the practices, the lifestyle changes necessary, or even getting on the appropriate medications that can help to prevent some of the these comorbidities.
Yeah.
In terms of fertility, it's not a nice thing to get blindsided by wanting to conceive and then figuring out that, oh, I've gone a year or 6 months and still haven't done that. That kind of messes with your plans for life, right? It blindsides you if you hadn't had a previous diagnosis of PCOS and then try to start a family and are having difficulty. It's even more frustrating if you don't have a diagnosis. So you're wondering what's wrong with me, or why can't I get pregnant? Once you do get pregnant, PCOS does put you at high risk for for maternal health and pregnancy complications. So it's really important to understand ahead of time to help to mitigate some of the potential complications that can come from PCOS.
And I think it's also important to not feel like it's all going to be doom and gloom, because I think, once you're diagnosed with PCOS and then you jump onto social media or go to Dr. Google, sometimes you're hit, especially on social media, you're hit with, oh, you're probably going to get diabetes, you're going to get this, you're going to get this, and then we'll get into the diet part. You can't eat this, you can't eat that. You're so overwhelmed and you just think like, my life is going to be horrible. I think it's important to know that there's so much that you can do from a nutrition, lifestyle, supplement, and medication if needed standpoint that can help a lot of this.
Yeah. I think in the PCOS communities that I've been in, a lot of the discussions center around some of the things that we have talked about, weight and fertility in particular. Because Sasha, we were just talking about that. I would love to go back to that question and talk about how PCOS might impact fertility or even pregnancy once someone does become pregnant, and whoever wants to take the question.
Yeah, so the high androgen levels, they do keep your progesterone pretty low, and that can maintain, you can sometimes get pregnant, you can achieve pregnancy in some cases, but sometimes you lose the pregnancy later on because the progesterone is unstable and it drops. So it's really important that you treat your PCOS to the best of your ability before you start going on that journey, because a lot of people start too early and then they have a miscarriage, and that just adds to the stress of trying to go back and trying to treat the PCOS in hindsight. So we always ask, that's the first question we ask our patients, okay, we're going to treat your PCOS, but what are your pregnancy concerns? Are you planning to have children? What does that timeline look for you? Because if somebody's like, well, I want to have a child, get pregnant next year, then that kind of changes what we're doing to get you to that goal.
Yeah. And anyone who's just joining the live, remember you can ask questions. Just put your questions in the comments and we will be able to pop them up here. As far as, keeping on the track of fertility, what medications might someone come in contact with? What discussions might they have if they do have PCOS and they are trying to have a family?
Yeah, so as far as, first we do a full fertility workup if that's already the plan for the year, that's the ultimate goal. And then we do have medications we can give you to treat the PCOS to the as much as you can, right? But then the truth is there's only some medications that are safe for the baby, for the embryo. So there's a big thing spreading all over the internet, Ozempic babies. Have y'all heard of that? It's like everywhere. Okay. And I get asked this question a lot. So the truth is semaglutide will increase your fertility. That's the other name for Ozempic. But it's not safe for the embryo. So those two things, those are two separate ordeals. So there's a lot of people using it because TikTok or someone told them to actually get pregnant, and then they'll continue taking it way after, they are pregnant, and that's not safe. So it's actually a 2-month washout, of which you should not try to get pregnant until we stop the semaglutide for 2 months. And there's only one medication that is safe to take throughout the pregnancy that helps you maintain your fertility and keeps the progesterone levels where it should be, and that is actually metformin. That is the only one that's safe to take. And then sometimes they might even say we're going to decrease the dosage. they'll keep track of that once we switch you over to your GYN and the OB. They'll take over at that point. So we just get you to the pregnancy point, and then of course we're telehealth. We can't do everything in telehealth. So you do have to get a GYN. People ask that all the time. They'll say, well, can you continue all the care? I'm like, no, we're telehealth, but we work very closely with your OB during your pregnancy.
I would also like to add that if you do have access to reproductive endocrinologists, that's the other doctor who specializes in infertility. And for PCOS, guess what the number is? If you've been trying for 3 months, it's time to reach out to a doctor. For the general public, maybe 6 to 12 months. But for PCOS, if you've gone 3 cycles or 3 to 6 cycles and it's not happening for you, go consult your gynecologist, who may refer you to a reproductive endocrinologist after they've exhausted what they can in for their practice. And just going back to something that Lindsay said earlier is, you may have trouble getting pregnant, but I'll also want to reassure people that PCOS doesn't not necessarily mean that you will have trouble getting pregnant. Actually, research shows that PCOS patients have the same amount of children compared to those who don't have PCOS. It just may take longer. And the earlier you're able to find a doctor or another healthcare provider, sometimes it only takes nutrition, right? So meeting with someone like Martha or Lindsay to help you to understand how PCOS is impacting you. It's all about individualized care, right? There's a lot of trial and error. We talked about Ozempic, but there are other medications that are contraindicated that are often used for PCOS to help lower the androgens. The anti-androgens are not safe for pregnancy, so you need to get off them at least 3 months before trying to conceive. And of course, oral contraceptives, the most commonly prescribed drug for PCOS, is also not helpful for someone trying to get pregnant. So there are lots of nuances around PCOS and infertility, but also wanted to give that glimmer of hope that PCOS doesn't always affect fertility, even though it is the most common cause of female infertility. But it doesn't also always have to be your story.
Yeah, and it's going back to what PCOS is, it's a syndrome. So that's like a really important key word. What that means is everyone might have this disease state, but we don't all have the same symptoms. So for example, like I had no issue with pregnancy, but I had just about every other symptom imaginable in my PCOS, but that one symptom. And it's different for everybody. That's why it has to be such a personalized journey, as Sasha mentioned. I mean, it's very difficult. Not any one of my patients is on the exact same plan. Just keep that in mind. And semaglutide did get added onto the 2023 PCOS treatment guidelines with the understanding that there's a 2-month washout before it's safe to try to start conceiving. So I think it's a great med to jumpstart PCOS if you qualify, if your weight is a BMI 30 or greater, but it's certainly not something you want. It is approved to take lifelong, but most people don't have to. Once, usually you can get to that point, it produces about 7 to 10 pounds weight loss a month. And when you get to your goal healthy weight, you can transition to a med that's less expensive, easier to take. It's not an injectable like metformin, or other medications, and also adding on diet and exercise. I tell my patients all the time, like, I can give you this medicine, but remember your insulin receptors are on your muscles. And if you're not working out and you're not eating well, you're going to have to take twice the dose of the medication to compensate, which means you might get side effects, right? And if you aren't taking your medicine, you might have to eat a lot less and you might have to exercise more to compensate for that. So we're very much holistic in that we treat everything from head to toe. We also treat a lot of what you mentioned earlier, mental health disorders, because that excess androgen can cause mood swings. Like, you used to hear about in the 90s, remember when people roid rage with men, they'd have inject too much testosterone. Well, we can only take so much testosterone in our bodies as women. And if we have an excess amount, can potentially be prone to changes in mood, but that's not everybody, or depression. And once you balance those hormones, a lot of that goes away or is minimized. So you actually might not need as much antidepressants or whatever it was you were taking before, because we've treated the root cause by balancing your hormones.
Yeah. I definitely want to come back to the nutrition element in a little bit. First, we're getting a bunch of comments, which are great. Please continue to put those questions in the comment section. I want to start with this one from Renetta. She says, can you explain if PCOS subsides as you get older beyond reproductive age? And if not, how is it treated? Whoever wants to take that.
I mean, yes. I'll jump in really fast, and then I'm sure you have something to say. I would say it changes. For some people, it becomes more metabolic as you get older. That's why it's really important to really keep tabs on the blood pressure, the cholesterol, the blood sugar. That's from my standpoint, it can change. And some people have more trouble with the hirsutism because you're exposed to testosterone for a longer period of time, and more difficulty with weight for some people. That's what I see.
Yeah, so there's when you do get older and you go into menopause, you kind of have almost like you have a new problem. You've got menopause right now, unfortunately. But the interesting thing about PCOS transitioning into menopause is that the way you can tell is it's about the ratio. So the testosterone might be really high. It's really high with PCOS, but it's also high with menopause, even if you didn't have PCOS in your younger years. But the difference is, so the ratio might be this high of testosterone and this much of estrogen, and you're young, you still have estrogen. You're not menopausal. Okay. And then when you transition to menopause, there's no estrogen. You see it. So now you see the bigger drop. You're going to experience those symptoms, sometimes worse. And a lot of the symptoms are actually common. So menopausal women share a lot of the same symptoms with PCOS women, for that same reason, that difference in ratio. So you've probably heard about menopausal women that never have PCOS that are like, suddenly I'm getting hairs on my chin, and and you're skipping your cycle, you're gaining weight in the middle, right? That all sounds familiar. Hair starts thinning. Those all sound like PCOS symptoms, right? So it actually, when you get to that age, we do have to differentiate between the two to appropriately treat you. But you'll know the difference because that estrogen won't be there at all, or it'll be very minimal, and the progesterones will change. But the symptoms are often almost exactly the same. So we actually have to do a lot of blood work to tease that out.
I also want to add that there isn't a lot of research in this area. As a matter of fact, for most PCOS studies, when you join a trial, most of them stop at 40. So we don't know too much about what happens in the perimenopause and menopause. We know by anecdote, by what happens clinically, but in terms of evidence-based information, there's not enough to understand what really happens to you with PCOS as you age.
I wish I was shocked that there was a gap in research with PCOS. Let me go to Meredith's question. This is actually a friend of mine. She said, how should I go about finding the best possible person for my PCOS care? She's in Charlotte. She's not sure if the gyno is the right person to go to.
Well, we do have some patients that fly in. I don't know if y'all are familiar with telehealth law, but you just have to be located in one of our states at the time of the visit. So we have patients from North Carolina, South Carolina. We actually have some people that fly in from another country and they sit in their hotel room or their car. I have patients that drive to the border and just sit in their car and get their phone and their camera on. That is an option. But if you are looking to stay in North Carolina, it really depends on the symptoms you're having. If you're experiencing a lot of weight gain and your BMI is greater than 30, that might be a sign because you're likely gaining insulin resistance. You might see the fat deposition increase first, and then the labs lag behind. You might need to go see an endocrinologist if your primary care doctor is not assisting you with the weight loss or the management of the insulin resistance. If it's mostly fertility, that would be reproductive endocrinology. So it really depends on the symptoms you're having. If it's early on, it's really interesting because primary care doctors, they might only advertise on primary care. It's really hard to know if that doctor has an interest in PCOS or they've taken continuing education in that. So you kind of have to ask around and ask, who knows somebody that has an interest in PCOS, is really focused on that. GYN handles some of it, of course, but it really depends on your symptom state to decide.
And Some people see if you can see a reproductive endocrinologist, if you have access to that, even if you're not trying to get pregnant, sometimes they may know more about PCOS. But in rural areas or medical deserts, or depending on your situation, that may not always be possible.
I think Heather asked a good follow-up to that one. Should you go to an endocrinologist each year for annual labs, or can you go to your family doctor to check blood pressure, A1C, other things you should be monitoring?
It depends. You could do your, go ahead.
Oh, sorry. You want to go ahead?
No, go ahead.
Well, it just depends on the training of your primary care doctor, your MD, or your family nurse practitioner, or your physician's assistant. So you have to find out what their background is. Because, for example, I'm a family nurse practitioner. My initial training was in primary care, but I took further training in endocrinology and hormones and other things. But they might not necessarily have that listed on their website. So it is very difficult to tease that out. So you can start with your primary care doctor, because a lot of endocrinologists, there's a 3-month wait list, or they won't even see you until they're referred from your primary care doctor, depending on your insurance. So that's a good place to start, and try to ask around and find someone that you know has a background in that. But you can also go to an endocrinologist too. They're required to have training in this, whether or not they have an interest in it or not. They will know the labs to order. I will tell you that. So an endocrinologist, primary care, GYN, it really depends on their specific research backgrounds. I always say, go to their website, look at their credentials, see if they posted any research they've done. If it's hormone or PCOS related, that's a good sign.
And I'll pull this one up. Megan says, I was wondering if you could tell us what are the best supplements for PCOS. I've heard mixed information about fasting. So maybe, Martha, this would be a good question for you, talking about nutrition to start. She said, and if it's good for people with PCOS to help lose weight, can you tell us your thoughts on fasting?
Sure. The supplements depends on the person. I like to start with, some blood work just to see, are you deficient in vitamin D? Vitamin D is a big one. It's actually a hormone, plays a very important role in fertility, insulin resistance, inflammation. So that will be the first one. If you're low in vitamin D, which most people are, you would need a supplement. I also like a supplement called inositol, and I like, there's myo-inositol and D-chiroinositol. I kind of like the 40-to-1 ratio. I won't give brand names, but that's one I like a lot. That one can help to regulate ovulation. It can help with insulin resistance. It might help to decrease androgens or symptoms. I think a lot of people can benefit from that one. I'm also a fan of, if you don't consume fatty fish at least 4 times a week, which most of us don't, I do like omega-3 fatty acids, a fish oil supplement. And I'm also a huge fan of magnesium. Most of us don't get enough from our food, and it's hard to get your blood levels checked. The blood work's not that accurate. So I don't see a downside to many people taking a magnesium supplement, especially if you have sleep trouble, like before you go to bed. So those are some of my favorites. And then the other ones, if you're on metformin, you should get your vitamin B12 levels checked, because you can have a deficiency. But the other ones are a little more nuanced, like do you need zinc or chromium? That I do individually with clients, but the ones I just named are my favorites. And then the fasting, I have kind of mixed thoughts on the fasting. I think I would first ask, what type of fasting are we talking about? Are we talking about, the 16 and 8, where you eat within an 8-hour window? Are we talking about alternate day fasting? Are we talking about time restricted eating, where you eat within, maybe a 12-hour window? So I would first ask, Megan, that question. But most people are referring to eating with like an 8-hour window. There haven't been that many studies done on women of reproductive age with intermittent fasting. A lot of the studies have been done in men, in animals, and maybe some older women. So I'm not a fan of it, but I will say, if somebody is eating within an 8-hour window and it's helped them lose weight, it's helped them lower their insulin levels, it's helped them regulate their cycles, they feel great, then I would say for you, maybe it's good. But for somebody else, maybe not, especially if they have high levels of stress or anxiety, or if they're a leaner type of PCOS, or if they get low blood sugar, if they go too long without eating. I'm not a fan of it for somebody like that. For some people, it could almost create more of a stress environment if they go too long without eating. And for them, it wouldn't be good. So I would say for most people, not a fan of strict fasting. For some people, maybe it would be okay.
How sustainable is it, Martha?
You know what? I couldn't do it because I like to eat. But I have some people, it really clicks with them and they think it's the best thing in the world. I guess if I had to think of a positive, if somebody's saying, okay, I'm going to, stop eating by 6 p.m. and they change their mindset and they used to snack all night. And now they say, okay, at 6 p.m. I'm done. No more eating. Maybe for them, it would be great. I'm kind of more about meal timing. There have been some interesting studies done that show if people eat more of their food earlier on in the day and less at night, there's been like 2 studies that I know of. It does improve insulin resistance. It might help with weight loss, ovulation, lower testosterone. I look more at that because I think a lot of people go all day, they eat minimally, they're running around, and then they sit down to have a large dinner. Then at night they want to snack more. Like that's not a great pattern. So if somebody wanted to kind of tweak the timing thing, I would say, okay, let's have a good breakfast. Let's have a lot of protein in the morning and some fiber. Eat more of your calories earlier on in the day. Eat a little bit less as the day goes on. If that's sustainable, some people don't like to eat that way, but it's great, I think, if somebody can do that.
This one is a bit of a specific question. Shay Alexa says, if someone suffers from migraines with aura so they cannot take estrogen and their body has rejected progesterone IUD, what other medications can stop abnormal uterine bleeding? Maybe, Lindsay, do you have any thoughts on that?
Yeah, so that is correct. If you have migraines with aura, okay, that's the absolute contraindication. Migraines without aura, a little bit of room there, but with aura, no. It increases your risk for blood clot, stroke, other issues. So a lot of patients their only choice is to take progesterones. And, there is, the IUDs, the hormonal IUDs are all progesterone based, but some people really, they can have mood swings with them. It's just basically too much progesterone in one area. So you can do progesterone only pills, and some people do respond better to those. And if you don't like it, the great thing about it is it's not surgically installed, right? You can quit taking it and then you can go change to another one next month. Whereas an IUD is a lot more of a commitment because you have to get it removed and changed out. There's actually a new progesterone only birth control pill that just came on the market, and there's not a lot of research on my patients. I haven't heard anything back on if they like it or not because it's so new. So I'm not going to necessarily say I recommended it, but it's called Slynd, SLYND. And it is the only progesterone birth control pill on the market that actually has an androgen blocker in it. And the jury's out if patients are liking it, because I've also seen where some of them almost like overblocked the androgens, and then you can overtreat PCOS. That is totally possible. But Slynd is progesterone only. It is kind of tricky to get covered because it is new. There's coupon codes, but that is something you could try out, or some of the other progesterone only birth control pills. But keep in mind, all progesterones have different androgen potencies, and a lot of them convert right back to testosterone. And that's a conversation for another day, but we are very picky about that. There's actually only 2 birth controls we even would ever prescribe to our PCOS patients, and that is the reasoning behind it. A lot of the other ones, the reason why people don't do well with birth control is because the rest of them are not the appropriate one for a PCOS patient. They were not made for us in mind, basically. And so what they do is a lot of the progesterone will convert back to testosterone while you're taking estrogen. So now you've got 2 problems, right? You've got too much estrogen, and now you've got even more testosterone, and they're kind of in a frenzy fighting each other is what happens.
Mm-hmm. Mm-hmm. I think this is a great question too, from Heather. What is the best way to eat if you have insulin resistance? Low carb, keto, tracking macros? I'm sure we've all heard 1,000 different ways. Martha, maybe do you have thoughts on that? Or
yeah, I have a lot of thoughts on it. In social media, it kind of makes it sound like you can't eat any carbs if you have insulin resistance, and maybe you went to your doctor and they said don't have fruit, don't have bread, don't have any of that. You don't have to be on a very low carb diet. The amount of carbs or the macros I recommend to my clients, it depends on the person. It depends really on their degree of insulin resistance, how active they are. Like if you exercise a lot, you're pretty active, you don't want to be on a really low carb diet. I like to kind of talk about balanced meals where you have some protein, some fat, a lot of fiber, and then carb. And when you kind of eat that combination of foods, you're going to slow the rise of blood sugar and insulin, then you're going to slow the crash. So for example, if somebody in the morning had, an egg with some avocado and some whole grain toast, like that's a perfect combination, and maybe sprinkle some chia seeds on or something, because you're getting kind of everything in there. So it's not like you have to be keto and only have eggs and avocado. You can have the toast, but when possible, have a balanced meal. And I feel if people take their carbs too low, first of all, carbs are good. They taste good. They're in a lot of good foods. You feel deprived. You feel restricted. And a lot of people end up getting some kind of disordered type eating if they're saying, I can't have any carbs and I can't have this. And then they'll end up binging, which happens a lot, actually. So I think allowing yourself to have carbs, but not going overboard when possible, and eating balanced. That to me is the best way to eat. Very few people need to go keto. Again, there's probably a small subset of people, maybe 5% or less, who do very well on ketogenic diets. They like it. It doesn't shoot their cholesterol up. Most people do not do well on ketogenic diets.
Yeah, I'm not a fan.
It's too hard to do, and I just don't think it's healthy. Like, are you getting your gut microbiome nourished and all that? But that's a whole other story. Tracking macros, I don't recommend people start out tracking macros. I do use it with some people when I've been working with them for a while, and one of their goals is to lose weight, and they're not losing weight after a while. We could track macros or do MyFitnessPal and track calories. But I think starting out, it puts too much pressure and anxiety that I have to meet these numbers. And I'd much rather people journal, write down the time they eat, what they eat, how they feel. When do they get carbohydrate cravings? How much sleep did they get? Just start to pay attention to how your body feels with the food you eat and your style of eating. And then slowly kind of make steps and you can make changes that way. But just jumping into MyFitnessPal tracking macros, it's like, I think it's way too anxiety provoking.
I've seen that too. I have some patients who did that a while and did develop disordered eating habits and almost like an OCD tendency. So I've had a lot of success with portion control plates. I don't know, Martha, if you have success with that. Yeah.
So I also think that there's a balance, right? A lifestyle balance. It's not just hyper focusing on nutrition, not just hyper focusing on exercise, which is what we're told, right? Eat less, exercise more. And then so that can create these obsessions and just feeling anxious all the time. Am I making the right choice? The goal to live healthy with PCOS is to enjoy life, right? That's the goal. Just like with everybody else. If something is not, one thing that's not helpful is being anxious all the time, right? We're already in a highly anxious state, the majority of us with PCOS. If something adds to that anxiety or adds to your feelings of depression and is lonely and isolating because you can't eat out with your friends, that's not the right thing for you. So it's about balance. Are you getting better sleep? Are you doing yoga or something that helps you feel less stressed? Are you going out with your friends? Are you connecting with people? Are you doing things that bring you joy? And it sounds so cliche, but eating is one of the pleasures in life that we shouldn't do away with as a human being, right? So just ensure that what you're doing is a balanced part of you trying to make the best choices for you living your happiest and healthiest life. And there's no one diet that works the best for PCOS. There's no, surprise, no good research on lifestyle factors for PCOS, even though that's the most commonly recommended management option for PCOS. So most of what we're told, 5 to 10 years ago, bariatric surgery was the the solution for PCOS and the solution for obesity with PCOS. And that's not the case. We can track people who've done some of these interventions, and if it's not sustainable, if it's not pleasurable, if it doesn't bring you joy and you're not living your happiest life, you're not going to continue with it, and it may have some adverse effects that we didn't plan on having, right? So find things that bring you joy and do those things.
I think that's a great point. And I want to touch on Ashley's comment, because I think a lot of people can relate to this when we're talking about eating healthy and, going to the gym, whether it's walking or Pilates or bar, whatever it is. Sometimes it's just hard to get out of bed. I think fatigue, correct me if I'm wrong, is a common something that people with PCOS suffer with. So Ashley said, I personally struggle with fatigue. It's by far the symptom that affects me most. Any suggestions for how to eliminate my fatigue?
This is probably the symptom I hear the most from people.
The most.
It's debilitating. And then you're hearing all these things. You're supposed to exercise this much and eat this way and eat organic. And then this fatigue. And I'll just quickly say something, and then Lindsay, you can jump in. The first thing, so it's very common with PCOS, partly due to the hormone imbalances, inflammation. But I would have some labs done first. Just rule out, have your thyroid checked, because there are much higher rates of thyroid disorders with PCOS. Check for nutritional deficiencies, B12 deficiency, low vitamin D, anemia. So check for that. And then there are high rates of sleep apnea with PCOS. So make sure you get screened for sleep apnea. Pay really special attention to your sleep. And I know it's easier said than done, but really work on your sleep hygiene and just do your best to get sleep. A lot of us don't make it a priority. And then you really want to look at your diet. Like, are you cutting down? Are you going too low in your carbohydrates? Are you skipping breakfast because you thought you're supposed to intermittent fast? Are you not having a good lunch? Like, really take a look at what your diet is. Are you eating balanced? Are you having enough carbohydrate, not too much, but not too little? And are you not pushing yourself too much with exercise? Sometimes your doctor says exercise more, and you're doing the wrong kinds of exercise, or you're working out too much. So that's kind of where I would start.
Yeah, and Martha brought up a really great point. So a lot of times it's the comorbidities that go along with PCOS. Like she mentioned, your thyroid, these heavy periods, right? So if you don't have your period for a long time, when you do finally have one, it is awful, right? Because all the periods you skip basically are built up on the lining of your uterus, and sometimes it comes off all at once. You can become anemic, you can become dizzy. So you have to, tease out what are the underlying side effects from PCOS that could be causing the fatigue. Also, the medication. Sometimes people come to me on a cocktail of inappropriately dosed medications. For example, metformin and any of the insulin sensitizers that are great for PCOS treatment have B12 deficiency as a side effect. It usually takes months and months for this to happen, but why not start off taking a B12 supplement? Why not take that in the very beginning with your medications? Or because of the depression factor, right? There's a lot of comorbidities with that. I'll look at someone's med list and I'll be like, wow, you're taking this causes depression. This blood pressure pill causes weight gain. This causes fatigue. So I always start with a full medication list, and I can usually, just by slimming down their medications or changing the dosages, a lot of that, can be resolved with the fatigue. And then just, when you feel tired, you don't want to exercise. It becomes a vicious cycle. So I think that's a big part of it. Also, progesterone, if you take too much. I've seen this a lot where they did go somewhere where someone gave them a huge amount of progesterone, way too much. It actually makes you sleepy, which is great for if you have trouble sleeping, right? But if you take too much, then you might be sleepy all day. Which brings me into, I'm glad you brought up sleep apnea, because they now have a study that was released. They used to think, well, PCOS women have that because they're overweight. We now know that for whatever reason, if you're over 30 and you're female and you have PCOS, you're more likely to have sleep apnea even if you're thin. For example, I have sleep apnea myself, and you can see my neck. I don't look like your typical sleep apnea patient, right? I don't have a really huge neck. And they really don't know why. They're still trying to figure out why is sleep apnea correlated with PCOS regardless of your weight.
Liz just asked, can birth control help you lose weight with PCOS? I think a lot of people will relate to this too. I mean, I've had doctors, and I know friends of mine with PCOS had doctors who said, if you're not actively trying to get pregnant, just get on PCOS or just get on birth control pills. I think also important to note, Liz says here that she hasn't had her period since May. So I don't know if that factors into your answer.
Yeah, so birth control has a limited impact on helping you lose weight. I'll be honest with you. It rarely, if you take too much estrogen, like there's different dosages of estrogen-based birth controls, and if it's a really high dosage, you can actually get weight gain. If it's the appropriate dosage, it's more likely that you won't lose weight, but because it prevents your PCOS from progressing because the androgen competes with the testosterone, you'll likely your PCOS won't get worse. So it's it won't help you lose weight. It's more like it just prevents it from getting worse in most cases.
Yeah. Mm-hmm. I want to go back to this main question because we've kind of skirted around it a little bit. We've talked about the genetic element and the nutrition and weight and obesity, but what causes PCOS? Do we know? And what are some of the maybe hypotheses?
It's no one really knows for sure, but it does run in families, and you really have to think about the history of medicine. So how long have women been concerned with women's health? The whole world hasn't been very concerned with women's health care in general. There weren't a lot of female doctors, female providers at all, so there wasn't a lot of research going on for a long time. And really think about it. I mean, birth control came out, in the 50s, and that wasn't that long ago. So we really don't know for sure. There's some studies being done on, is it like the hormones and, the food we eat, like, what is it? Is our lifestyle, because we eat a lot of preservatives now in America. We don't have the best diet here in general. So it's really, they're still doing research trying to figure it out. Do y'all have any up-to-date research studies that y'all seen recently?
PCOS is seen all around the world. It's a global issue.
Mm-hmm.
Certain environmental triggers exacerbate certain things in PCOS, like you're more prone to getting diabetes or cardiovascular disease, perhaps if you're not walking enough, or perhaps if you're exposed to certain endocrine disrupting chemicals. But someone in Nairobi with PCOS still experiences some of those things, right? They still experience the propensity for gaining weight, the challenges with fertility. It runs in families. They're still trying. They've identified genes. They've identified multiple things, but PCOS research is still relatively new in its infancy. It's extremely underfunded, and so it's going to take some time for us to get the answer to this question, right? It's been over 80 years since PCOS first got a name, right? And there's been an evolution of understanding about PCOS and how it impacts people differently and how it impacts our lives. But yeah, the answer to this question is still elusive. You can line up 20 different researchers, 20 different healthcare providers, and they'll all have, just like the syndrome PCOS, will all have a different combination of answers for you about what causes PCOS.
Lindsay's question about not getting her period since May just reminds me of me when I was first being diagnosed and I hadn't had it for 8 months and everyone was telling me it was fine. Is it fine? Is it dangerous to not get your period?
So this is I'm so glad you brought this question up, because this is very confusing as well. So when you don't have your period and you're not on a birth control, it means that the uterine lining is building up. It's just not coming off. And those old cells are prone to mutations and they can become cancerous. So the biggest risk there is uterine cancer. Now, if you are on a birth control, this is where people get confused. It prevented the lining from building to begin with. So there's nothing to shed. The best way to think of it is there's just nothing there to come off. So that's a different situation, because I have had patients say, oh my gosh, I heard what you said, you can get uterine cancer if you don't have a period. And then I'm like, okay, but you're on a birth control. So you didn't have anything to shed to come off. It's people that aren't on a birth control and they have a lining that's building up and it's not coming off.
I have a couple of comments about the best way to lose weight. Heather's asking if resistance training is better or walking. I've had people wonder about cardio. And then Lynn's asks, what's the best way to lose weight with PCOS? She's eating healthy on the treadmill. I remember, when I was first diagnosed, I was going to Orange Theory, like very heavy cardio, multiple days a week.
No.
Yeah, that's what my doctor said too. So can you talk a bit?
So,
I'll jump into the exercise part. There are a lot of myths out there about exercise. I think exercise is just as confusing as nutrition when it comes to PCOS. Like you hear people say, don't do any vigorous exercise because it's going to cause cortisol spikes, which is bad for PCOS. So you should just walk and do slow and low in yoga. But then you hear other people say, no, you have to do more cardio to lose weight. In the ideal world, there would be a combination of exercise. There would be a cardiovascular component because that's going to help decrease the risk of heart disease. It does help with insulin resistance. It's good for mental health. I think the intensity of the type of cardio depends on the person. There are Olympic athletes who have PCOS and they're not exercising low and slow. They're exercising vigorously, but not everybody can do that. So if you feel best by doing a brisk walk, do that. If you feel good taking a spinning class, do that. So, but you don't want to overdo it. Like, especially if you're having irregular cycles, you're feeling very stressed. If you're overdoing the cardio, it can make things a lot worse. But don't be afraid to push yourself a little bit if it feels good. They've done not a lot, but they've done some studies on HIIT, high intensity interval training with PCOS. It has a lot of benefits. But if you're doing it 5 times a week, not so good. If you're maybe do it twice a week. So I think finding an aerobic or cardiovascular type of workout, also adding in resistance training. And that's an area I find a lot of people don't do because they're afraid of getting bulky. They don't know what to do. They're afraid. Building muscle, and most people are not going to build a lot of muscle. Yes, there are higher levels of testosterone, but most people aren't going to get really bulky. When you build muscle is what helps to suck the sugar into the cell, and it helps to improve insulin resistance. Normally, in order to get carbohydrate from the blood into the cell, you have to make insulin. And the last thing you want to do is keep making a lot of insulin. So when you have the muscle there, the muscle is like sucking the sugar into use for energy, and it's helping to dispose of glucose, which improves insulin resistance. So I would recommend weight training 2 to 3 times a week, and then doing cardio. Realistically, how much time do you have in your life to do all this exercise? But maybe cardio 2 or 3 times a week. And then try and get some steps in, because every time you get out and you walk, again, you're helping with insulin resistance. Not everybody can hit 10,000. I tell people to get a baseline. If your baseline is 3,000, maybe you aim for 5,000. So I like that. And then if you have the time, throw in a yoga class. Yoga to me, it's more of a mind-body thing. They've done studies on yoga helping to lower cortisol
resistance training.
Yeah, so it's not this vigorous, hot yoga, super, super intense, more of almost like a more of a restorative or a bit of a calming yoga. It can help also. So
I just wanted to say to Linz that, kudos to you for doing everything that you thought you were supposed to do, right? You're doing the best you can with the information you have. So you're eating healthy, you're hitting the gym, literally doing HIIT, and gained 15 to 20 pounds. This is not uncommon with PCOS. This happens so often when we're doing all the things that they tell us to do, all the things at the same time, but just in the incorrect balance, right? For you, your diet is probably great if you change up your exercise, pay attention to your stress levels, like Martha said, do some walking, add some yoga, which can also double as strength training, right? We're doing some downward facing dog, building muscles in our arms, things like that. So don't be hard on yourself. Be very proud of yourself, because the majority of us don't do all of the movement that we're supposed to be doing, or eating the way we're supposed to be. So kudos to you for taking this seriously and taking your health into your own hands.
And sometimes, like Lindsay, sometimes like you're doing everything right, without me knowing details about exactly how you're eating. And the frustrating part is, like, you're doing everything right, and maybe your exercise program is perfect and you're not overdoing it. So sometimes it involves trying to tweak something or change something. And also meet with your doctor. Maybe you had like a flare up of insulin resistance. Maybe you would benefit from metformin. Sometimes when I see people go through life changes, they go to college or they leave college, they get a stressful job. And like the stress is like driving some more of this insulin resistance. So really pay special attention to the stress in your life, get enough sleep, and maybe look at, maybe make some changes in your diet, make sure you are doing enough protein. Maybe you would benefit by tracking on MyFitnessPal for a week or two just to get a baseline and see how much protein are you getting in, how much fiber. Maybe you need to make some changes. I mean, it looks like what you're doing is great, and maybe you don't need to make any changes, but I like trying to say, okay, what can we do differently, kind of thing.
Yeah, I think a lot of the confusion with this, with the question, people ask this a lot, is we don't know exactly the level everyone's cortisol is going to spike, right? Any amount of stress can make one person's cortisol spike, and for somebody else, it's not that much at all. So like having a target heart rate for your age, some people want an exact number. They're like, well, Lindsay, like if I'm doing cardio, how much is too much? Because that is scientifically true. You can exercise so much, the cortisol spike will actually drive up your testosterone, which makes you plateau. Okay, so it's really the things like really intense cardio, overdoing it, like Martha mentioned. And patients always say, well, what is this cutoff? How do I know? Because everyone's monitoring their heart rate. And I always say, well, I mean, look at the target heart rate for your age, for your height, for your weight, for your age. And if you're way out of line of that, then yeah, that's probably too much, right? So resistance training, like Martha mentioned, your insulin receptors are on your muscles. That's like a large population of insulin receptors. So when you use your muscles, you're stimulating them. So you are actually lowering your testosterone by using your muscles indirectly by lowering your insulin resistance. So that's why resistance training is a definite add-on. So when people say, well, I only run, I only do cardio, I always say, let's add on resistance training and see what difference that makes. And it usually makes a pretty big impact.
Are we also tracking things other than weight? Mm-hmm. So, how do you feel in your clothes? How do you, how do you feel after you do these exercises? These are really important indicators as well as to, one, are you going to stick with it? And one, is this the right type of exercise for you, or the right type of style of eating for you? So I think it's just thinking about balance and not frustrating yourself and piling everything on at the same time.
Mm-hmm. Yeah. I know I've kept you ladies over an hour, so we'll wrap up here shortly. Lawson, if you're still here, we did talk about this briefly in the beginning. If you want to go back and watch, I want to end before we get everyone's final thoughts with Abigail's question. Hopefully that's pretty straightforward to answer. With metformin, is it recommended to stay at the same dosage, or should that be fluctuating over time based on lab results? And I'll also add to this, because it was a question I got yesterday, which is, do you have to be on this for your whole life, whether it's, an Ozempic or a metformin or, whatever medication you're on to help with your symptoms?
Yeah, so we do titrate it. That is what's recommended. Also, there's immediate release, extended release. I see a lot of patients that think they can't tolerate it because they were given the immediate release, which causes immediate diarrhea for a lot of people. Do not recommend that. Now we have the extended release, and you have to start slow and slowly increase the dosage. That's another thing I see some providers don't do. They just give them the maximum dose all at one time. Of course, they're going to be sick. Of course, that's not how you should titrate it. So yeah, you should, of course, the more you take, the more effect you get, but for the more you take, you could have side effects. So we do have to slowly increase it, monitor it, ask how you're feeling as we titrate it up. Most patients do, what I've seen, have to take at least one medication lifelong for their PCOS, so that it helps them to respond to diet and exercise better, so that they don't have to work out 5 days a week and not eat a lot to maintain their weight. It just makes it easier to respond to the diet and exercise, so that they can exercise maybe 3 days a week and take the one medication. Rarely do I have someone that doesn't take anything at all. But a lot of patients, they might start off on 3 meds for PCOS And when their weight gets down, when everything is stable, we check their hormones and we can actually get it down to 1. And then if someone has really mild PCOS, sometimes it is possible to do diet and exercise, but that's usually if you catch it really early. And unfortunately, because of what we talked about earlier, a lot of women aren't getting diagnosed for 20 years when it's been out of control, right? So I definitely recommend getting diagnosed early when the symptoms first occur, so you can catch it before all these other metabolic issues occur.
You're good. Yeah, that's great. And so, I think each of these topics we could have a whole hour-long Zoom session on, honestly, each of these questions. But I don't want to take up too much of your time. So I would love to get everyone's final thoughts. So we'll go by each of you and just your final thoughts overall, things you want people to take away from this conversation, things that, you've learned or gleaned from your experience working in this area, just kind of overall conclusion as we wrap up here. And Sasha, would you like to go first?
Sure. Just remember that you, as an informed patient, you are an empowered patient. So the more we know about PCOS, even, filtering through all the confusing information out there, focus on you, focus on how it impacts you. Ask questions of your healthcare providers, be your own advocate. And remember to keep balance and introduce joy, things that make you happy, into your treatment plan with PCOS, regardless of what your goal is, whether it's to lose weight, to get pregnant. Just remember to keep it balanced and keep it joyful.
I do want to follow up on that, Sasha, real quick, because it just made me think while you were talking. A lot of people who have PCOS are struggling with infertility. I'm in a lot of these like Facebook groups and Reddit threads. And I think to your point earlier about the mental health aspect, it can be really draining, not only on the person who has PCOS, but also, their partners, their families. Do you have any advice for, dealing with that?
Yeah, I've been through everything from the anxiety, depression, infertility. Infertility caused by fibroids and PCOS. Have had to have multiple surgeries, and now I have an almost 2-year-old. But I understand the ups and downs of the fluctuating mood outside of dealing with infertility treatments, but going through infertility treatments puts it on another level. Mm-hmm. So having that support, giving yourself grace really is foundational, but also being better at communicating your needs to those who support you, whether it's your partner, whether it's your family members, because a lot, as we mentioned earlier, PCOS can be isolating. Sometimes you're eating differently than everyone else. You're having to do different things to maintain a certain weight or a certain look, right? To keep facial hair at bay. This is a really stressful life for a lot of people. So having that support system with your family members, there's no need to suffer in silence anymore. An empowered patient is a person who understands how it impacts them and, also help others to help them as well.
Yeah, that's awesome. All right, Lindsay, what are your final thoughts to wrap us up?
I agree with Sasha. I would say education. Education is power. I know that's been overused a lot, but it's so true. Because when you feel like no one understands your condition, you don't understand your condition, you just feel almost, just out of control. Like, who's going to help me? I can't help myself. No one can help me. It can really just create so much anxiety. And I think education and empowerment, being your own advocate, selecting your provider, they don't select you, you select them. If they don't, if they are not doing the labs that, according to the 356-page 2023 PCOS guidelines, if they are not doing those labs and they're not following those guidelines where the world's greatest minds have come together and done a meta-analysis with all the data, then you need to ask why, and maybe even take a printed copy, show it to them. You really have to advocate for yourself. And if anyone needs a copy of that, it's on my education resource tab on my website, PCOSsisters.com. And we also have a free pure bar class to add on to the resistance training here in Decatur, Georgia, coming on September 22nd. If anyone is interested in adding on resistance training, we're actually sponsoring one of their classes. So
that's awesome. I know a lot of people, Abigail included here, have asked about how to find providers. So I guess my last follow-up question for you, Lindsay, would be, any recommendations on finding the right person to treat it? And can you just trust any doctor to know what they're doing? I mean, I think that answer there is obvious, but how do you really trust that someone knows what they're doing with what feels like your whole life and potentially the future of your family too?
It really comes down to, if they put their background on their website, and interviewing them, come into a visit, and, we offer free 10-minute consults. You can, do that on our website if you aren't ready to schedule the actual visit, where it's just a phone call and we just make sure we're the right fit. So I think having that first meeting and interview is very important, because there is no PCOS specialty, right? It's so many different disciplines of medicine and branches all rolled into one. So we see patients, of course, here in Atlanta, the whole state of Georgia, Florida, New York, Texas, and some people drive into the border. So we've been able to reach people in rural areas that otherwise would have never been diagnosed, would have never been treated, or they might drive 3 hours to receive a diagnosis. So all that's changing. It's getting a lot better.
I think it says a lot that there are people driving from other states and other countries just to get PCOS specific care. And we touched on it earlier, and this again could be a whole nother hour-long conversation, but medical deserts and people not having access to medical care period easily, let alone, to this level. So this has been an awesome conversation. Martha, we'll wrap up with you. And what are your final thoughts?
I would say to really try to do your best not to get overwhelmed. I just think once you start Googling and going online, you're hit with, you have to take these 10 supplements, you have to eat this certain way. And here you are, feeling really fatigued, and feeling overwhelmed. I think it's trying to don't believe everything you read online. Find some people who you trust. If somebody's pushing their agenda, like you have to go gluten-free, you have to do dairy-free, you have to do this, especially if they're selling programs, they're selling supplements. There's some great people out there selling supplements, don't get me wrong, but if they're pushing something on you and they're selling it, just be careful. You want to find people who have a more balanced approach, when possible, get some evidence-based information, but people who are more balanced, and because that's the worst thing I think you can feel, that you have to do all these things and you almost can't do anything because you feel so overwhelmed. So be careful on what you believe. Set very small goals for yourself. I like to say to people, maybe set 1 or 2 goals a week. Maybe be trying to go to bed 15 minutes earlier or to get off your phone. Just set very, very small goals. Start to have a breakfast. And then I also like people to say, focus on some positive things, rather than say, oh, I'm really upset because I didn't lose any weight. Think about, okay, well, my energy's a little better. I'm able to take a walk in the afternoon. So I think as you start to make these small changes and focus on positivity and other things besides just the scale, I think you'll go a long way. It'll really make a difference in the end. It's just with these small goals.
Yeah, definitely. So finally, how can people follow you guys or the work that you're doing?
So we're PCOS Challenge, PCOSchallenge.org. This month is PCOS Awareness Month. We're the sponsoring organization for PCOS Awareness Month. So you can also go to PCOSawarenessmonth.org to find out about all the activities that we have going on all around the country and even in another country as well.
And the lightings, tell us about the lightings of the buildings.
Over 400 landmarks around the world are lighting up and have already started lighting up teal in honor and in support of PCOS patients around the globe. This is record-breaking support and is a testament to the power of advocacy, the power of patients using their experiences and their voices to create change. 10 years ago, we were ignored every time we reached out to ask for support for PCOS patients. And now there is hope. So every time you see a building light up teal, think reaching out to PCOS Challenge, helping to advocate for yourself and others with PCOS, and know that there is hope. And we're working very hard for positive outcomes for everyone affected by PCOS.
And a huge shout out to Sasha and Will from PCOS Challenge. The work that they put into this, with a young child, I just don't even know how they do it. They are just constantly on the go, constantly advocating. I don't even know how they do it. So huge kudos.
Thank you, Martha.
Yes.
And how can we reach you, Martha? You never said.
I am the best place to find me is on Instagram. I am the PCOS dietitian with periods, because there's lots of dietitians of PCOS. So the PCOS dietitian. You can get my website from my Instagram profile, and I try to post there regularly. I have lots of free downloads there. Or then if you go to my website, I have a blog on PCOS, and you can get my website from my Instagram profile. So that's where you'll find me.
Martha was one of my first Instagram follows when I was diagnosed. She posts great stuff. And Lindsay, what about you?
Yeah, so you can find our website, PCOSsisters.com, and that's sisters spelled traditionally, sisters.com. We're also on Instagram, PCOS Sisters Telehealth, if you want to follow us there. And yeah, you can make an appointment directly on the website. It's self-service. And if you aren't ready for an actual appointment, you can do the 10-minute free consult just to make sure we're the right fit. And we have tons of events coming up. So we're actually hosting a 5K in person in Orlando this weekend, September 7th, and virtual the entire month. So even if you're in the Atlanta area like I am, you can still do the virtual option. We mail you the t-shirt either way. We get asked that a lot. You still get the t-shirt even if you're virtual. And then there's also the Pure Barre class that we're sponsoring here in Decatur this month. And of course, PCOS Con is coming up. So I'll be speaking there, but yeah, don't forget to wear your teal this month. We just started a whole marketing strategy with dogs of teal, and you can make your dog dress up in teal for the month or however you want to do it. But they did have men of teal, it's a little play on words. So we're introducing the pups into the mix. And I am wearing teal. I don't know if y'all can see that, but it is technically teal. I didn't realize it didn't show well on the camera, but yeah, PCOSsisters.com or PCOS Sisters Telehealth on Instagram.
Well, I really cannot thank you all enough for joining me and giving us an hour and a half of your time. The work you've all done in this area is so inspiring. It's made people like me feel a lot less alone and a lot more empowered. And this conversation has made me feel the same. And I hope it has for others as well. Thank you guys so much, really.